So Gemma, you might have to talk to me and tell me when to start. I can't quite see any chat at the moment.
Okay, yeah, we've got about 800 on, so let's get going.
Right, are we live?
Yes, we are.
Hello, well, good morning, everybody. Welcome to this Health Foundation webinar, the Health and White Paper Unbound. As you know, the Department of Health and Social Care published on the 11th of February the white paper with legislative proposals for changes to the NHS in England and a few other bits added in. And what we're going to do today is look at the main thrust of the white paper and examine some of the elements and what they mean. You might have already seen some of the hearings by the Health Select Committee that are taking place on the subject. Simon Stevens and Amanda Pritchard gave a good go and clear testimony earlier this week on Tuesday, worth a look, and other stakeholders have been doing the same. And I think Matt Hancock is in line to be interviewed next on the white paper. Well, today it's our turn. We're going to give it a good go. So just a few words on the white paper itself. In the white paper, the Department of Health and Social Care were at great pains to say that the proposals weren't the sum total of changes it wants to see on the NHS social care or public health. It's meant to be a partial view and incremental, and largely to remove barriers that are stopping progress, in particular bureaucratic barriers that it makes great pains to set out. So is this white paper just a pragmatic tidying up exercise, or is it something more profound? And what else needs to be done if it is incremental? And can we glean in it any bigger government project for the NHS and social care and public health in the years to come? Is there a strategy at all, or is this just bits and pieces, if you like? So I'm Jennifer Dixon, and I'm really pleased to be your chair for today's webinar. We've got an hour to kick the tires on this one. And to help with these questions, I'm really pleased to introduce three of our expert guests. First, we have Hugh Alderwick, who's the head of health policy here at the Health Foundation, and he'll kick off by outlining some of the main changes in the white paper. Then we're really lucky to have Sarah Price, who's the chief officer from Greater Manchester Health and Social Care Partnership, and she is going to respond. And then she'll be followed by Nick Timmins, who's a senior fellow at the Institute for Government and the King's Fund, and he will give his take as well. And then what we'll do is get to some Q&A where we're going to address some of the many questions, great questions actually, some of you have already posed, and also more that you may pose during the seminar as you hear the speakers. If you like a question someone has posed, you can do something called upvote it by clicking on the thumbs up section in the chat box. So have a look at that. And if you like the questions, give it a thumbs up. And what I'll try and do is cover most of the most popular questions, as many of them as I can in this session. And finally, for seasoned Twitterati, please use the hashtag THF white paper. That's THF white paper if you want to tweet. So let's get going, as we've just got an hour. So I'm going to hand over now to Hugh to kick off and tell us what it's all about. Thank you, Hugh.
Thanks, Jennifer, and hi, everyone. I think Gemma's going to share my slides, but I think my main job here is to give you an overall summary of the key proposals in the white paper. I'll give you some reflections as well on what I think are some of the big issues and questions which Nick and Sarah can build on. I think I've got about 10 minutes, so I'm going to stick to the broad contours and the biggest changes, which will hopefully provide a decent framing for the rest of the discussion, but clearly won't be comprehensive. So first, we've got some background here, just so we all know what we're talking about. Jennifer set some of this out. So here on the slide is the white paper, very exciting, snappily titled Integration and Innovation, which sets out a mix of changes, and it is quite a mixed bag. To the way the NHS in England is organised and governed. Now, broadly speaking, I think the main thrust of the changes in the white paper, and most of the time dedicated in the white paper, is on changes to try and encourage collaboration in the health system, so to better integrate services at a local level, better integrate planning. The title of the white paper suggests this is about health and social care, but really this focuses mainly on the NHS with some much more limited proposals in these other areas. So in the paper itself, the department divides the changes they set out into four broad buckets, which you can see on the slide. When I talk through the proposals, I'm going to simplify that a little bit and talk through what I think are the three main parts of the story that are going on. And before we get into it, it's worth having in the back of our minds that the idea is to do this all quite quickly, which relates to the questions Jennifer was raising about, is this just pragmatic, technical, small fixes that can be done without much disruption, or something bigger? So government and NHS leaders want the changes to be implemented from April next year. So Jim, if you can go to the next slide. So before we get into the detail of the proposals and what they mean, you might very legitimately ask, and I think some people have in the questions submitted before the webinar, why on earth are we talking about changes to NHS legislation now when we're still in the middle, hopefully towards the back end of a pandemic? Well, one answer is that for many people in the NHS, changes to the law, to legislation have been a very long time coming and are needed basically to tidy up the mess that was left by the last round of major NHS reform back in 2012. So on this slide, you broadly plot a timeline of some of the key policy developments over the last 10 years that have led to the white paper we saw last month. So you'll probably remember nearly a decade ago on the left-hand side of the slide, the coalition government introduced the Health and Social Care Act, which broadly speaking tried to encourage competition as a big route to improve local health services. But in doing so also created a very complex, very fragmented organizational structure. Now, since then, these bluer papers in the middle of the timeline, NHS leaders have ignored large parts of the legislation and actually tried to embrace collaboration between different parts of the NHS and local government instead, driven forward by two big plans, the 5-year forward view back in 2014 and the NHS long-term plan in 2019. And to help join up services and overcome the fragmentation in the system, NHS leaders created various kinds of partnership structures. Many of you will know about these, first called STPs back in 2015, 2016, then evolved into ICS as integrated care systems, which play a big role in the white paper. But the challenge has been over the last few years that those new partnership bodies don't really have any formal powers, which can make working together quite difficult. And they still bump up against the rules on procurement and competition in the Health and Social Care Act. So the basic idea from an NHS perspective has been to try and resolve the tensions between the formal rules for the NHS and how the system actually wants to work in practice. It's quite a long way of saying that the Health and Social Care Act nearly a decade ago sort of sets the scene for the changes we're talking about now. So Gemma, if you can go to the next slide. So if that's the context, hopefully that was helpful. I think, what does the paper actually say? So for me, this is a story of three big parts, and I'll talk through each of them really quickly. Part one is a set of changes wanted by NHS leaders to try and improve collaboration, as we talked about. Part two is much more politically driven set of changes proposed by government to try and increase ministerial control over the NHS. And then part three are the things that aren't in the white paper. Perhaps that's legitimate, perhaps it's not, but the limited fixes that we see in the white paper to much bigger problems. So let's start with part one. Jim, if you can go to the next slide. So this is the biggest chunk of the white paper. And the most important change here is to formally establish integrated care systems in the NHS Statute. So these are area-based partnerships between the NHS commissioners, providers and local government, currently operating informally in about 42 parts of the country. Some of those 42 aren't yet formally called ICSs, but they soon will be. Confusingly, under the new plans in the white paper, every area of England will actually have two ICSs. So one NHS agency that will be responsible for strategic planning, allocating most of NHS funding, and then one partnership ICS involving local government, other community groups, whose role is much looser in the white paper, but seems to be about making a plan that the NHS ICS should stick to. CCGs would be abolished, their functions taken on by this integrated care system, and then each ICS, or well, each couplet of ICSs will be joined by two other kinds of partnerships. The organogram gets quite complicated. One is more local partnerships in places between the NHS and local government, probably are based around local authority areas. And then the second is compulsory partnerships of providers, so hospitals, joint practice and so on, in each ICS area. And then finally, to help local organisations work together, requirements to competitively tender clinical services will be ditched, though again, exactly what will replace them is not clearly set out. So what are we supposed to make of all of that? Gemma, if you could click. So I think overall, the emphasis on collaboration, working together between agencies clearly makes sense, fits with the direction the NHS is already taking. But there are some key issues that we can talk through in the next hour. I think one is the benefits of the kind of integration on offer in the white paper, which is really about rules, structures, risks being way overstated. One big reason being that formal duties to collaborate or mergers of functions don't necessarily produce collaboration in practice. There's also lots of questions about how ICSs will actually work in practice. It's not clear what power ICSs will have over providers. It's not clear how the two ICSs will interact. Is this really going to be an NHS domination, which might undermine the goals of partnership that stood behind the first versions of STPs? And also standing back, there's a ton of partnership boards now. This gets quite difficult to explain to somebody, quite difficult to draw on a diagram. So is there a risk that the system becomes quite complex? And then finally, there's a risk of disruption. We know that creating new agencies, even if they exist in informal form right now, is much easier on paper than in practice. So part two, Gemma, if we can click. The second bit of the story is a bit different. This is about national powers and responsibilities, and this comes later on in the white paper. And this is about national system, not the local system. So there's some changes that are proposed to try and tidy up the way that national NHS bodies work, like formalising the merger that pretty much has already happened between NHS England and NHS Improvement. But the white paper also includes a much broader set of powers that would give the Secretary of State much tighter control over the day-to-day running of the health system. So that includes powers to direct NHS England, transfer functions between arm's length bodies, abolish them, and also to intervene at any time in local service reconfiguration, scrapping the system that works at the moment for referring to an independent panel. So Gemma, if you can click, Nick is going to talk about this chunk of the white paper in more detail, so I won't do it too much here, but on the face of it, I'd say these are the sort of set of proposals around boosting ministerial control that don't have much clear rationale and could have unintended consequences and big risks, including making service changes more political and other risks you could think about. I think there's also a question about have we learnt the right lessons from the pandemic. A leaked draft of the white paper a couple of weeks before it actually came out seemed to suggest that the pandemic had illustrated the need for changes to a national accountability. But I think it's quite hard to see how closer ministerial control would have boosted the NHS's pandemic performance. So we're still sort of left thinking, what is the rationale for these changes? How will the new powers be used in practice? And then the final part of the story, Gemma, if you could click, is about what's not in the white paper as much as what is. There are three areas in particular where we get very limited proposals when clearly much bigger fixes are needed by government. Now, as Jennifer said at the beginning, it could be that these are coming later, but it's worth highlighting nonetheless. So on workforce, for instance, the white paper includes a duty for the Secretary of State to publish a paper once a Parliament setting out who's responsible for what on the workforce. But if we look at the system right now, what NHS and social care desperately need is a long-term plan now, setting out what the workforce need in the future might be, how those staff are going to be recruited, retained. We still don't have one. On public health, there are some limited measures in the white paper on obesity, public health responsibilities. But again, after the last year we've had, what the country desperately needs is a cross-government strategy for tackling sort of the wide unjust health inequalities that we've all seen exacerbated by the pandemic. Again, we don't yet have one. And then finally on social care, perhaps where the rage is most justified, we see some very targeted policy fixes, some of them fine in themselves, but a very long way from adding up to the much more comprehensive reform that we know is needed to provide more effective, generous support for vulnerable people and their families. And standing back from those three areas, I think it's worth pointing out that without reform of social care, without adequate funding for public health, local government, the other objectives in the white paper around the NHS and the role in improving population health are going to be really difficult to meet, particularly if we continue to disinvest in those wider services. So finally, before I hand over, next slide, Gemma, I think it's worth standing back from the detail of the proposals and what's in the white paper and thinking, how does this fit within the longer run direction of the NHS? Two ways of doing that. One, I think, is looking backwards. As lots of people on the webinar will know, this is a white paper that stands in a very long line of previous NHS reorganisations. So while over the first 30 years of the NHS, its structure was pretty stable, but over the last 30 years, we've seen lots of reorganisation, lots of change, particularly on the commissioning side of the system. But overall, the evidence tells us that previous reorganisations have delivered little measurable benefit, and other policies to support the system, like investment, boosting the workforce, redesigning services, are likely to have had a bigger effect on performance. We also know that reorganisations can have negative effects, however unintended, destabilising services, additional costs, destabilising relationships. So the risk is that, depending on how these plans are implemented, how far they go, that we distract from the task of recovering services after COVID. I think also worth pointing out, it seems like the proposals take the NHS policy-wise much further back towards a sort of pre-1990, pre-purchaser provider split course. I think the purchaser provider split isn't dead, but the emphasis is on collaboration, not competition. But I don't think it's clear we've learned enough about the last 30 years of health policy to inform the latest round. For instance, what have we learned about the various forms of commissioning, and how is that going to inform what ICSs do and how they function? And then looking forwards, a couple of quick points to make. I think the first is obvious. So the scale of the challenges facing the NHS after the pandemic are huge, addressing the big backlog of unmet healthcare need, fixing staffing shortages, and the challenges on health facing the government are even bigger. So action on inequalities that we've talked about, action to address the sort of stark, scary increase in child poverty, destitution. So now this white paper is just tiny in comparison to those big problems, and it can only do so much through this legislation. It's about rules and structures. But given how much has changed over the last year, I think what's still missing from an NHS perspective is a narrative about how those changes fit within a new guiding strategy for where the health system is going after the pandemic, and how COVID has affected what we can deliver and what we're aiming for. Hopefully that was a helpful overview. I think I'm going to stop there. I've probably talked for my 10 minutes and a little more. Back to you, Jennifer, I think.
Thank you, Hugh. I thought it was a really clear overview. And perhaps if I can just sneak in a quick question. So clearly it looks like this white paper is a game in two halves. On the one hand, there's the long march towards more integrated care that started 6-7 years ago, perhaps even before that. And this is the latest development of that. And then the other is, of course, this centralisation, or at least some elements of that, with the Secretary of State's powers. So in your view, looking at the balance between those two, is the balance towards more autonomy, do you think, with local autonomy and freedom to make changes through the ICS mechanism? Or do you think that there is this worrying sort of spectre of centralisation that is appropriate, inappropriate? What is the balance of those two halves?
That's a really good question. They're related, aren't they? So one answer could be to split them and say, well, actually, the white paper is quite good on describing flexibility for local leaders on ICSs, on places, setting their own priorities, working out who needs to be on boards, because that's a good thing. And then separate to that is this sort of strengthening ministerial grip and power. But I think there's a risk that the second undermines the first. And actually, is there going to be more political intervention, central intervention on what NHS England does, and therefore by default what ICSs do? So on the one hand, I think we should welcome the emphasis on collaboration, flexibility for local systems, but I think we should be very worried about the second half less benign changes that are politically driven, that actually could make it much more difficult for an ICS to actually feel they've got that freedom, particularly if there's also intervention on the service changes that local leaders want to be making. So yeah, the temptation would be to say there's two halves, one's better than the other, but actually they're closely related, aren't they? And I think the mindset, if you're a local leader, Sarah can tell us this, is that if there's stronger ministerial power at the centre, NHS England is not being left alone to develop its own strategy, then perhaps they won't quite feel that flexibility and that autonomy is real, even though it's written down in the white paper.
Thank you so much, Hugh. So that's great. That asks my question of Sarah, which is, Sarah, your views on the white paper as a whole are terrific, given your fabulous perspective in Greater Manchester. But I think that initial point about whether you feel this gives more autonomy, even as sitting in a devolved city region, if you like, whether this white paper gives you more flexibility and freedom, do you think, to pursue integrated care? I think that's the first sort of element to kick off on. Thank you.
Thanks, Jennifer, and thanks, Hugh, for your thoughts as well. I suppose just that if you read it on the just reading it straightforwardly, you think, well, absolutely, this enshrines everything that we're trying to do in Greater Manchester to deliver that integration. So, you know, all the long-term plan, 5-year forward view, all pushed us towards fully integrating with local government, and in fact across the public sector is how we would see it in Greater Manchester. So the initial interpretation of the white paper is this is just a formalisation of what we're already doing, but I think the big question will be how permissive is it? It's a word that's being used readily at the moment, but in reality, just having seen some of the proposed guidance, or the areas that there's going to be guidance, I can see a tsunami of things that are coming down the line that, if we're not strong enough, could mean that it is that very central control that we're all trying to move away from. So for GM, on the face of it, it could be a really great thing, but it could be something that pulls us back from where we've already got to over the last 5 years, as we come to the end of our first taking charge of health and social care in Greater Manchester, our programme that set out our devolution journey. So I suppose in terms of things that we would really be supportive of, you know, the emphasis on improving population health outcomes and reducing inequality, absolutely at the heart of what we want to do. Place-based partnerships, which is where we've seen some of the real strengths in development and our ability to really move things forward, and a more streamlined and strategic commissioning as opposed to more tactical commissioning, I think could be really positive. And then provide a collaboration. We've seen the strengths of that in Greater Manchester over the last year, as the hospitals particularly have worked much more effectively together in order to address the challenges that we faced through the pandemic. I think we would, in Greater Manchester, support the move away from a sort of a more adversarial and transactional system focused on contracting and activity payments, definitely. One that's more collaborative and dedicated to tackling those shared problems, I think we're already showing make a difference. And it's why we've placed such importance on those health outcomes, such as school readiness, good work, secure housing, not just for our waits in A&E and whether or not we're achieving 52-week waits. Those things are very important, but those broader challenges are the ones that are going to really make the long-term difference, and one where the NHS has somewhat been reluctant to take part in. And I think in GM we've really embraced that and really seen that as part of our job. You can't deliver it through one sector alone, and it's not just health services, is it? I mean, we all know that. So we're, as I say, really pleased to see the removal of those competitive procurement rules that stand in the way of integration. I mean, I think in Greater Manchester we've done really well in not observing the rules, but working together to see how we can best apply them to forward our thinking. And we've argued for these changes for some time, so our submission suspending reviews and things like that have picked up on this. I suppose one of the concerns that we've got is that if there are changes in the NHS around this, it needs to be commensurate in local government, because obviously if you're going to integrate, you need to be able to do things together in the same way. If they're still restricted by procurement, then we're going to struggle to be able to do that. I I suppose place-based arrangements are at the heart of our GM model, and obviously in the white paper, and that's helpful. But we need to be able to establish accountable place-based boards in our 10 local authority, 10 districts, and control of resources for the population they serve is a real priority. And we need to be able to secure that through the negotiations. So while the legislation hasn't been put down, it's still unclear whether or not we're going to have the freedom and flexibility to be able to do that. And it highlights the importance of both the governance and the financial framework for the ICS enabling and connecting into those places and that place-based working. Because without this, you haven't got the resource to be able to work together at community level, and you take decision making further away from those communities. Duty to collaborate, all great, but it will be the detail on what that actually means. And I think the rigid monitoring that Hugh referred to, if we're constantly answering up to the NHS, then we'll be able to move things forward. And a lot of the changes that are already underway in GM are kind of there, and some of the changes we've made during COVID-19. With teams at the front line removing those barriers. We don't want to go backwards now while we wait for legislation to take us forward, if you see what I mean. Things that we feel a bit less comfortable with is the rapid progress we've made on integration when places have aligned political, clinical and managerial leadership. And the role of democracy is largely absent from the white paper. The mentions of accountability or democratic legitimacy relate principally to the powers of the Secretary of State, as mentioned earlier. It doesn't support a health service that is rooted in place, and it does risk distant control from Whitehall, as we've just been discussing. I think there's a real tension too about having two boards. It's interesting calling them an NHS board and a partnership board. It does feel very 1990s, doesn't it? Those two have got to be working absolutely hand in hand. I think we were very disappointed to see that there would be two separate boards. We were hoping that there would be one. So there is a risk it could pull us back from the way that we've been working. Place-based budgets at scale are a real feature of the current GM model. Some of them are, they're in the hundreds of millions, where, we've got one locality where I think the budget's about £1 billion. 600 million in another, 480. We've got absolutely massive joint budgets. We need mechanisms replacing Section 75 that allow us to be able to continue to run in that way at place level. The words better care funds send chills, really, because we've been trying to argue that that's passé for a very long time. I mean, it just seems such small beer compared to what we're doing, and rather concerning that we're still seeing it as a way forward. On a similar note, we found it's hugely beneficial to have elected politicians as the chair of our board since its inception. The white paper indicates that NHSE will publish guidance on the appointment of chairs. We want the flexibility to maintain that kind of model. We remain concerned about the absence of a long-term financial settlement for social care. This undermines progress on health and social care integration. We make the same point about public health finances as well. The white paper proposes new powers for the Secretary of State, as Hugh mentioned. We hope that this is not going to be the beginning of a trend towards greater national control of social care as well as health. Our experience tells us that social care will only thrive through place-based models based firmly and anchored in those local communities. Some of the work we've been doing around discharge over the last 3 months even, without that integration, we would not have achieved some of the flow that we've managed. And over the whole of the year, the work we've been doing with care homes, because social care is such a big part of what we do, and the Directors of Adult Social Care are key partners in that, we've done some really great work. And then the formal merger of NHS England Improvement, hopefully the relationship between the new body and ICSs reflects the spirit of the white paper. But again, as we said, we want people to step away from excessive specification of detail and monitoring. Instead, we should seek to drive improvement through transparent reporting of outcomes, peer challenge and support, and facilitation of learning between ICSs. We need to do things differently. We've got to model a different behaviour. And it'll be interesting to see if the new oversight framework is rested on a progressive model of improvement support and not rely on old notions of assurance, which have been shown to work, not to work. Our experience of performance improvement in social care quality, mental health access, for example, share characteristics with sector-led improvement approaches that local government have been champions of. Some of the changes proposed relate to delegations already made to GM in respect to public health and specialised commissioning powers. We've developed a system-wide approach to population health that's really stood us in good stead during the pandemic, but the need for local control is something that needs to be emphasised, and some of those delegations that we've already got need to be reconfirmed. So finally, we think the proposals could be much stronger on the potential role of ICSs in health creation, working with combined authorities and local government. ICSs can bring together the full range of contributors to health benefit within a system, including wider public services, business, civic society and the VCSC. We are doing this in Greater Manchester, including our work with Michael Marmot and his team on what our framework around building back fairer should be. And it's only through working in this way that we think we can create the conditions for people to live longer, healthier, happier and much more fulfilled lives. Thanks, Jennifer.
Sarah, that's a very comprehensive analysis, and also very useful to hear from your on-the-ground experience in GM. It sounds as if broadly these proposals are going with the thrust and the grain of what you want to do in Greater Manchester, with possibly one exception, which is this democratic point that you made, and actually several questions have been about, well, actually about the patient voice, but about democracy. And as you said, this twin-headed kind of couplet, as Paul said, between the ICS NHS body and the ICS partnership, with the kind of relationship between the two not entirely clear. How would you propose to increase the democratic accountability of these integrated care things? Is there something that you can modify with these proposals, or bypass or work around or strengthen?
So one of the things that we're in kind of our model going forward is we think that we need really strong locality boards. We've delegated authorities from, or spending authority from, what will be the ICS at GM level. So those locality boards need to set direction, work in an integrated way, and political, managerial, clinical inputs need to be at that level really, really strong, VCSC, etc. What we're looking at is how at a GM level, do you have a core membership that overlaps, that allows you to take the very best of what we're doing already, locality representation in those boards, and what the overlap would be. It's not clear yet what the kind of requirements will be of the NHS board, but if it turns out to be a very separate body, and you can't have that real overlap, then I think that will be more challenging for Greater Manchester in terms of the involvement that we've had to date. I mean, we think we'll be able to have Richard as our chair, our health and care lead portfolio holder, but there are challenges in that for us.
And those locality boards would be coterminous to local authorities?
Yes, sorry, yes, it would, yeah.
Okay, that's great. Thank you, Sarah. That's great. So Nick, over to you now on your take on it, and in particular this theme, which is the central and local theme, in particular with what Secretary of State has their powers. And there's a very nice, rather oblique references to why the Secretary of State wants to have more control or powers over the NHS, including one which said these proposals will allow the Secretary of State to set clear direction in a more agile way over the NHS, which is quite interesting. So it's quite oblique as to what the problem is that some of these statements try to solve. So your analysis here would help clear the murk. Thank you.
Well, I thought that one of the more extraordinary bits of the white paper was this proposal that there should be fresh powers of direction over NHS England and the health service more generally from ministers, and in the leaked white paper that was justified as that the pandemic had shown the need for this. I suspect most people's view of the pandemic has shown rather the opposite. I mean, if you look at Public Health England, it was the executive agency of the Department of Health, so Matt Hancock could tell it what to do. But what he actually did in the end was decide it was no good and disbanded it into 2 new bodies. And test and trace is absolutely the Department of Health's minister's responsibility. And I think, most people would not regard test and trace as being a hugely successful exercise. Indeed, Sir Nick Macpherson, the former Permanent Secretary of Treasury, has just described it as the most wasteful and inept public spending programme of all time. But these are the bits that ministers directly control. And I would say one of the successes of NHS, about the only success of the 2012 legislation has been the relatively greater independence of NHS England as a statutorily independent board. So the question is, why do ministers want these new powers? And there is no explanation in the white paper about that at all. And one hopes that when Matt Hancock's in front of the Select Committee next week, the Select Committee will ask him to spell out what is it he has not been able to do without these powers of direction. If the answer then isn't clear, when it gets to Parliament, Parliament should ask those questions. And if it's not clear, they don't think these powers should be granted. I mean, there's all sorts of risk in this. It's actually not, by and large, I don't think, in the health service interest that there should be additional powers of direction and lots of intervention from the centre. Command and control has never worked terribly well. But I actually think it's in ministers' own interests. I think they will regret this if they take this and start taking these powers, because centralisation of power does lead to centralisation of blame. And you can illustrate that from the NHS's past history. So they are taking a big risk here. So the question, they need to explain why these powers are needed, what they will do. And the other thing that was slightly remarkable about Hancock's statement in Parliament, which was going on about the need for NHS accountability, as though NHS England is completely unaccountable at the moment. Well, it is accountable. The way it works is that there's this annual rolling mandate, which ministers set the marching orders for NHS England. The deal is that NHS England has to agree the mandate. Now, this provides the opportunity to say, well, if you want us to do this, we need resources to do that. Or you need to change this to allow us to do it. So it has to be an agreed programme. And I think in most businesses, you would recognise if you want to get your business division to do something, you agree what it is they're going to do. If NHS England says no, then Hancock can go to Parliament and say, I am directing NHS England to do this. I'm putting this in the mandate, they don't want it. But he has to explain why and justify it to Parliament. And that seems to be pretty transparent and clear, but it is accountable. And the board, and therefore Sir Simon Stevens as the Chief Executive, is held accountable for doing the mandate to ministers. So this myth that there's no accountability at the moment is a myth. So again, we have to ask the question, what is it he has not been able to get the NHS to do without powers of direction? So that's kind of the sort of national level stuff. I mean, I don't know whether you want to go into some of the other things. I mean,
sorry, can I just, because on that, Nick, these are great points. And as you remember, you and I interviewed Jeremy Hunt in a podcast a few months ago, didn't we? And one of the critical things he said, which is quite interesting, is that there was nothing he felt he couldn't ask or request of NHS England.
Yeah, well, indeed. I mean, he is absolutely on the record saying he never felt the need to have powers of intervention. Exactly. He is the longest serving health secretary.
Exactly. And just to plug your book, The Glaziers and Window Breakers book, where you interview all former secretaries of State for Health that are alive, I think most of them, it almost doesn't matter what's written down. It's the relationship between the Secretary of State and their conception of the role and the Chief of NHS England or the Department of Health.
Yes, I mean, there is a broader point, which you could argue slightly undermines some of what I've just said, but there is a tendency for behaviour to trump legislation. You know, what makes these things work are relationships, and that's absolutely true at Sarah's level in Greater Manchester, as it is between ministers and the senior civil servants, and in these days the NHS chief executives and what have you. You know, relationships do tend to trump precisely what the legislation says, and we've kind of seen that since 2012, when in many ways the 2012 Act has been ignored and just worked around and put aside. But nonetheless, some of these form positions do, I think, matter, and I still hold the view that if ministers decide to start intervening left, right, and centre in the NHS, they will come to regret it, and it won't be good for the service. You know, and again, there's this interesting bit. If you look at intervening earlier in service changes, what we call reconfigurations in the jargon, you know, that's presented as we can do this earlier, so it will be better. You know, we'll get decisions quicker. you do worry about that, because the history of ministerial intervention in service reconfigurations is not good. I mean, just take one example: St Heliers on Epsom, in just south of London. Proposals 2003. These are hospitals with very, very tired fabric for the most part. The proposal replaced them with a new hospital in Sutton, which is partway between the two, and that got all the way down the road and was killed off by ministers at the last minute on the bizarre grounds that the arguments for and against were very finely balanced. So because the decision was to go ahead, they reversed it. We are now reaching the stage where that hospital is going to be that new hospital is going to be approved, and that's 17 years later. It'll be 20 years by the time it's built. So there's clearly a good case for a much faster, I mean, leaving aside examples like that, there's clearly a good case for handling service changes faster. It's a very bureaucratic and slow progress the NHS has. But ministers intervening, I suspect most of that will be political pressure not to go ahead with something because of the difficulty that the NHS always faces. It's very hard to paint the picture of what will be there and improved in future when all people see them losing some current services. And there is, behaviour trumping legislation. There's an example right now where Matt Hancock has intervened over plans to reshape the Chorley A&E up in Lancashire, and that clearly has come from pressure from the Speaker, who's a local MP. This does not bode well.
Yeah, and it's kind of repeated in the white paper. So you have to ask what's underneath this if it doesn't really relate to reality. Why would it possibly be in there? This business about the Secretary of State wanting more powers, at least in theory. For what purpose is this a useful thing to put in?
Well, I suppose the pressure is that ministers are accountable for the National Health Service locally, and they do get a lot of pressure from the public and from MPs about things, and they kind of want a bunch of levers to pull that can make all the things they want happen. But it doesn't work like that.
No, it's almost the demonstration that this is needed that is the political point, isn't it? I'm just sort of mooting.
Well, I mean, I just go back to the point. Tell us what you're not able to do, spell out in detail, and one would hope there's several examples of this, not just one.
Yeah.
What is it that ministers have not been able to get the NHS to do that they wanted to do because they lacked powers of direction?
Yeah. Or what do they want to show that what do they want to give an impression that they don't have the levers, that they didn't have the levers, and therefore they need more? Anyway, so that which might be a more of a political positioning point. I mean, sorry to be so cynical.
People have different views about how accountable the NHS should be to ministers.
Yeah.
But having the distance is in ministers' own interests in some ways. I mean, if you go back to that dreadful winter of 1718, ahead of the 70th anniversary, which is really bad. It was the one where the Red Cross garnered itself headlines by saying it was the rescue of the NHS and all that sort of opportunistic. Anyway, but Hunt was having to defend that. He was on the broadcast media all the time, and was able to sit there and say, this is really dreadful. I apologise. It should not be happening like this. We are doing our very best to cope with it. But he kind of survived all that in a sense because it was the services that, we're trying to get the service to do this. So he was both responsible and not responsible. So it is in minister's own interest not to try and actually run the thing entirely from the centre, because they will centralise the blame on themselves. And there's a long history that trying to run it from the centre does not work.
Yes. So we'll wait to see.
I'll just stick this in as an aside and I'll shut up, which is partly why, of course, we're getting ICSs, because if you look at the long history of the NHS from 1948, there has always been a regional tier until the 2012 Act, which abolished it entirely. And what's been going on since then, they've been slowly been reinventing it through SDPs and the ICSs and what have you, and we're now going to put it back on a statutory footing. So that's a long lesson too. That sort of tells you can't do everything entirely locally, for reasons I could go into if you like, and you certainly can't run it all from Whitehall. So we're back to a regional tier.
Yeah. So in terms of the very simple question, do you think this white paper indicates a rebalancing of the central local? What would your response be really to that? Do you think it looks as if the attempt to have more autonomy locally is a chimera, and actually.
Yeah, well, I mean, the honest answer, I think, is it will depend how ministers behave, assuming this bill goes through. How ministers then behave.
Yeah,
they've got powers of direction, so they use them left, right, and centre, or do they stand back and say, no, what this is really about is getting people, at different levels out there, from the sort of ICS level, which worries about secondary, tertiary services, to what service people keep out the local place stuff, which is where you really tie general practice and social care and community services together, and we're devolving it all down there, and that's what this is all about. It will depend upon behaviour. Yeah. But what it will do is give Secretary of State powers that currently he does not have, even though in practice he can behave as though he's got them.
Thank you very much. Very interesting. Good, thank you. Now, our audience have been extremely patient. They've asked lots of really interesting questions. So I'm going to come to some of those now, and I'll put it out to all of you so you can jump in as you wish. So I think one question is about, there's a worry about the sense of patient voice being lost, and indeed choice being lost in these rather large monopolies, if you might call it, monopoly set of provider networks. And I know this was a question asked in the Select Committee on Tuesday. Do you think that the patient voice, A, and B, patient choice, has been weakened through these proposals? And if so, what do you think needs to happen to boost it again? So perhaps if I can turn to Sarah, who's closest to all of this.
It's really challenging, isn't it? Really difficult, because obviously you want services to be really responsive to local communities, and so the kind of the thrust around integration at a local level and the involvement of communities in shaping how things work could potentially be really fabulous. And if people are given the freedom and flexibility to be able to do that, then I think it could be really responsive, the engagement of VCSE, etc. But then on the other hand, so in Greater Manchester, given the inequality we're seeing, we've had and continues to, and given the work we've been doing with Michael Marmot showing that those gaps are growing, that being able to ensure that we address those probably is going to need some form of coordinated approach at a GM level, I think, in terms of making sure people have access to services in the same, whether you live in Oldham or the south of Manchester, or whether you live in Salford or Tameside. If you've got clinical need, we need to be able to do that in the same way. So can you do that if there's open and free choice, and if people who are disadvantaged perhaps don't access services in quite the same way? The people that are good at it will get there first. So how do you balance that off? So all important. Thank you, tea delivery. all important, but I think I would. We need a balance, don't we? So it's about how do you involve people at those decision-making levels to make sure that they're engaged, and the sort of the formal patient choice thing, I think, might be something we need to think about.
And given, thank you, Sarah, and given the backlog, and given that patients may want to be looking around to see where waiting lists may be more conducive to their condition, they may want to go out of area. Are these proposals saying anything about their ability to do that, to maybe leave Greater Manchester and be treated somewhere else entirely different if they feel that their condition is going to be treated more quickly? Hugh, I don't know, Nick, whether you have views on this particular aspect of the white paper.
Yeah, a couple of points. So first, on the community patient involvement, but I do think this comes down to how the ICS couplet thing actually works, which Sarah set out. I mean, there is a risk, isn't there, that the NHS, it becomes an NHS regional board, like Nick described. This goes back, is it a strategic health authority, or is it a regional health, whatever it is from the part, and it's an NHS thing, and that there's this separate ICS partnership board that might have great representation from community groups, from patient voices, but what power do they actually have over this NHS thing that might become quite healthcare focused, might become quite hospital focused? There's lots of big towns in hospitals. So how is it actually going to work? I would like to see, well, there needs to be local flexibility, how the arrangements work, who's involved at a local level. We do need to know what in practice are the teeth here and health and wellbeing boards have been more and less successful depending on the arrangements at a local level. What is the teeth for community groups to actually influence what could be an NHS regional agenda? I mean, that's the worry. I shouldn't think that this would change dramatically the ability to choose. And the question is more how are commissioners going to be selecting local providers if competition is out? There's lots of potential benefits to that, but there's also a risk of coziness and lack of transparency, which would need to be addressed at a local level. And we're still yet to see, I think it's being consulted on at the moment, what the new regime will be for provider selection. So I think that the detail is yet to be developed. There's also then this place level, which is the lower one, which is probably where all the action happens from a community perspective. You know, it's where I am, it's, you know, it's Camberwell or Lambeth. It's not Southeast London. But again, with CCGs scrapped and it being about ICE, it's not really clear who the NHS partner is at that level. Again, there's good flexibility left in the white paper to work it out. Potential risk that this is going to get put onto PCNs, which are much smaller. They're tiny in comparison to a local authority area. So it's also a bit murky at that level in terms of who are the people involved, how will they actually hold this delegated budget. So yeah, I think Sarah's right, potential benefits, but a real risk that this becomes an NHS thing without enough community involvement. I don't know if that answers the question. I think it half does.
No, I think it does. And just turning to Nick, is this the last sort of is the huge tidal wave or that's crashed over the NHS since '91, which is to use competition as a sort of driving force to create change, whether or not that's successful? Is this the very end of is this white paper representing another receding of that wave?
Well, it's certainly the wave receding. I'm not sure it abolishes it entirely, but yes, I mean, I've always thought the big difference with the Lansley Act, the 2012 Act, was if you go back to the Conservatives period up to 97 and Labour thereafter, the use of choice and competition was one of the tools they used to manage the NHS. There were plenty of others. I mean, in Labour's time, there were waiting time targets, targets for all sorts of bits of waiting time. There was a very vigorous performance management of that, and there was some encouragement of peer review and what have you. And the choice and competition agenda was another tool they used. Now, you could argue that was all a bit incoherent.
Yeah.
The difference with the 2012 Act was this was meant to be the only way the NHS was to be managed was by choice and competition. And clearly that's been hugely rolled back. It never happened is the answer. It's been rolled back and it says roll it back. Does this get rid of choice? I mean, it doesn't reinforce choice. I don't see it should get rid of choice. It's perfectly possible to within this system to say you had some choice over where you go to get your treatment. Mm-hmm. The patient and public voice is all a bit complicated. I mean, this is, I think, relevant. I do worry slightly when you look at these structures that are proposed to be put in place. So there will be this NHS ICS body. There will then be the partnership board with local authorities. The health and wellbeing boards will still exist. Scrutiny and overview committees will still exist, though without the power to refer reconfigurations to Secretary of State, because that's all changing. The primary care, it does look a rather crowded field. And you slightly wonder if, when there is disagreement, how will decisions get made? And I'm not saying this, I've been my worst nightmares, your horrible feeling this feels a bit like heading back to the consensus management of the 1980s, where you couldn't do anything unless everybody agreed. So everybody in practice had a power of veto. I think the partnership boards have happened because local authorities are split in their views about this. So I think some would like to have had a single body, single ICS, local government body, but I mean, kind of like Greater Manchester really, but where they actually took direct responsibility for what was going on. And other local authorities said, well, we want to say what's going on, but we don't want to cede our bit of sovereignty, which in a sense you do when you mix it with the NHS body. So I think this has come as a sort of compromise because local authorities don't have a united view about what their relationship should be. And of course, it's partly through local authorities that the public voice comes in. And we talked about how important it is that in practice, if you're making changes to get better integrated care, these happen very locally rather than at ICS level.
Yeah. And on that, there's quite a lot of questions that have come up about whether or not the white paper speeds up action to tackle inequalities in health, in population health inequalities. And from what you've been saying, Sarah, at least, it looks as though that the white paper does help accelerate some of those changes.
Well, I think if you think back to 2013, one of the things that happened was with the transfer of public health into local government was the responsibility was seen to transfer. And I know in my past, I was trying to persuade NHS that they had a role in reducing inequality. They said, oh, no, that's local government view. So I know we've moved on since then. 5-year forward view started to set that out, and certainly in the long-term plan, that's beginning to be prioritised. But there is the potential here by making it a key strand of the white paper that we can start to do that. But the challenge will be budget. You know, if can we allocate money to areas like, so for example, some of the investment we've made in Greater Manchester over the last few years have been in helping to stop people fall out of work. Because we can see that helps health and well-being in the longer term and use of services. But you can see that if you go down a very NHS route, that won't be seen as a priority alongside cancer, mental health. And I guess that's another issue. If too much money is coming down these individual shoots rather than coming down to the system for then the system to determine how to apply across health need, then I think we won't be able to address some of those inequalities.
Particularly if the provider collaboratives are quite dominant, the hospital sector still, and we know that from some of our analysis over the last 20 years, if you look at the way the resources have been allocated in places, the hospital sector has actually got the lion's share of the growth over that period, and primary care has still more or less. Now we've got 4 minutes to go, and we're going to have a kibosh that just comes down at 10:30. So maybe just chance for one more comment, and then I'll wrap up. So Hugh, on population health.
Yeah, just really quickly on that. I think these regional local partnership boards are one potential mechanism that could help reduce inequalities. But let's not go wild. I think public health is still chronically underfunded. Big real terms cuts in the budget. Do we even have the grant for next year out yet? I don't think we do. It's pretty gruesome. So, you know, unless you're going to invest in services that keep you healthy, having a partnership board is not going to fix the underlying structural issues that determine health inequalities. So this could help, but show us the money. I think the second point I'd make before we go is, I think Nick made a really important point about behaviours trumping legislation. At a national level, one big thing to watch out for, at the moment we've got Simon Stevens, probably the most talented politician in London, not even a politician, who can set a strategy for the NHS, who can get money out of the Treasury. So he can probably work with the new arrangements. But who's next in terms of leadership for the NHS? Is there a risk that the changes to national accountabilities actually become much more difficult and do lead to greater centralisation of power if he goes? Parting shot.
Great, thank you. So I think we've given this quite a good go. We've only had an hour. I think it's important to remember with the white paper that it is only a small partial view of what needs to be done. There's clearly loads of stuff that needs to happen to help improve both health services and also population health that cannot be put in this kind of white paper or be on the face of any bill. Tackling inequalities and the government and the need to have a cross-government sort of inequality strategy seems to be pretty major, linked to levelling up. That the dots aren't joined on that. We haven't got progress. And also another big area for clinicians who've done so much and so fast in the pandemic. The talk that we've just had must seem like Martian talk, mustn't it? It's all about, it seems about administrative deck chairs, it seems about levers. When you think of the kinds of things that affect frontline care, a lot of that's going to be to do with management, to do with technology, to do with investment, which really this white paper doesn't cover at all. So there's obviously more fish to fry on that front too, and not even mentioning social care and the huge change there. And absent it all, as I think you've all more or less said, is that there doesn't seem to be inclinations for an overall strategy other than a bit more grip from the centre. So it's murky, but I think we've given what's in the white paper quite a good kicking, and I think the general thrust is that it does go with the grain of what people want to do. However, the powers of the Secretary of State seem to be a bit worrying in how they might bear out in future with this or another Secretary of State who feels the need and interest to intervene. So this will be continued. Thank you very, very much for participating, to all our speakers, to Sarah, to Nick and to Hugh for giving it such a good go, to all of you who have listened in, stayed in, over 1,000 of you, which is incredible, and for all your questions, which some of which we came to. Don't worry, to be continued, and join us again in future. We have the next corporate webinar, which is about public mood on the NHS and how that might influence the future shape of care. That's next month, so please join us there. Please join our podcast. Next one is on Biden's uphill task for the US healthcare system. That's for policy wonks only. And for more information on the white paper, please have a look at our website and our newsletter. And thank you very, very much, everybody. Please join us again and for this journey into further developments of NHS and social care and public health reform. And hope you enjoyed it. Stay well. Thank you.